Africa's strategy to attain universal health coverage is to implement a national health insurance system. The rollout of this plan has, however, been delayed in the past by legislation and the COVID-19 pandemic. Last year, the Portfolio Committee on Health in Parliament deliberated on the NHI bill, but there were no significant changes made to it. We are now joined by Dr. Kgosi Letlape. He is a doctor, obviously, and an ophthalmic surgeon. Did I get that right, Doc? Thank you very much for joining us this afternoon.
Good afternoon to you and the viewers. Yes, you got it right.
Thank you.
Ophthalmologist.
There we go. Thank you. You learn something new every day. And so according to President Cyril Ramaphosa, during the State of the Nation address debate session, he said that South Africa is committed to the provision of quality healthcare for all, regardless of their ability to pay. He said we will therefore progressively implement the National Health Insurance, the NHI, as soon as the necessary legislation is approved by this Parliament. What have you made of the processes that have been ongoing in the background to make this a reality and the delays that have been ongoing?
You know, there's an expression that sometimes the road to hell is paved with good intentions. And I think having a national health system is a good intention. And the key should be on the system rather than just on funding. But concentrating on the funding of healthcare, if it is going to be a national health insurance, it has to be for all of us, which means one port for all citizens. Whether I'm a bricklayer, whether I'm unemployed, the state pays for me, whether I'm the president of the country, whether I'm an MP, whether I'm a judge. One system for all of us. That is what would make it national. We need to be cautious about creating what we call a national health fund, which can just be a pot of money for poor people, which may have poor outcomes as well.
The finance minister announced the budget and allocated money to healthcare, but hearing nothing of the national health insurance plan. And so when you take a look at some of the conversations that have been going about with the national health insurance, with some sectors of society saying, yes, let's give this a go-ahead, and other sectors of society pointing out that, well, how do we get one plan right when we are not even able to get public health care to work for those who need it? Which is all of us, essentially,
well,
actually.
The problems are much bigger than that. And I think part of the problem why the public hospitals don't work is because the privileged are not using the public health care. Privileged like myself and you do not use the public health care for our own care. So we have apartheid in health, which has become normalized. And that's the key reason. It's the separateness. Because if we and the president had to go to Bara for our care, it would make sure that Bara is up to scratch. If we go to a different place, no wonder the public healthcare system is in tatters. And as long as it is public healthcare for the poor and its separateness in healthcare, it'll never come right. Now, this notion of saying fix public healthcare before you bring us the rich in is nonsensical, unethical, and it's basically a crime against humanity. These things will only work if they are for all of us. Health has to be a national competence. Health must be run by the National Health Ministry, central protocol. We're going to decrease what could be termed medical loss ratio, where you have money that goes to non-healthcare costs. The admin is too much. When you look at the NHI that is being proposed, there's a new admin structure that is being proposed. When at the same time, under the authority of the Minister of Health, we have the Council for Medical Schemes. What is the Council for Medical Schemes doing? What is that expertise of over many decades going to do? Why are we now creating an admin system that sits inside the Department of Health for a new insurance system? It's the same. We are creating too much bureaucracy, and that needs to be guarded against. So we need to begin to ask the question, if it is not for all of us, it is not going to work.
Doc, you speak of the health being a national competence, or it must be a national competence. And this privilege that you put to you and I, it's not sustainable, right? Because there are certain things that you actually do need to go to a public hospital for. I think of someone that I know who has TB, who has to get medication from Baragwanath Hospital, and they cannot get it, this particular medication, through private healthcare. And so at some point in our lives, it's going to touch on all of us, right? And so when you speak of health being a national competence, or must be a national competence, there is, though, something to be said about fixing healthcare, not for all of us to get onto it, but fixing it even for the people who are accessing it, which sometimes will be you and I. You've got people who wake up at 2 a.m. in the morning so that they can be seen by a nurse or a doctor at 7 a.m. If you're lucky, you will leave that public hospital by 3 p.m. And so are there not systematic problems that we need to desperately fix so that it benefits all?
Let me highlight it. This problem in the public healthcare sector, amongst others, is underfunding. You go to Bar, they're given a budget that does not meet their last year's actual expenditure. And the demand for their services keeps growing. How do you expect them to run their hospital? And when you give them less than what they spent, their actual expenditure of last year, they'll have debts and outstanding people that have not been paid from last year. So that budget goes in. Look at the detail of the minister's comments, the finance minister, on health allocations. He's trying to put allocations so that we can employ people into the system. But that money will never get to the posts because the system is porous. The system owes too much. And next year, you'll still have young doctors, young nurses that can't be employed when we need them, when we have trained them. We don't even have the resources to absorb the human resources that we need into a public healthcare system that we have produced from our training institutions. We are on a hiding second to none. So unless you bring the two systems together, where the rich, the affluent like you and me subsidize our aunts and our cousins that have no means, that we work together, health will never work. This self-aggrandizement of saying, oh, it's not working, fix it first. It's not working because it's for the poor. It's not working because of separateness. Now we find an excuse that now says that, fix it first. Let us not kid ourselves. If we want this thing to work, it has to be for all of us. When I talk about health being a national competence, we have one SARS commissioner. Provinces don't have their own collection of revenue systems. And SARS is one of the few things that work in this country. Why do we need to have 10 health ministers? We only need one. And more money goes to administration that doesn't add value to healthcare. Let it be centralized with policy. Remember, when Charlotte Matleke bent down, there were problems fixing it. And when we try for accountability, oh, this is a provincial competence, oh, this is a national competence, oh, this is public services. This is not, I can't fix the hospital because it sits in another department. One of the problems we have in South Africa is too much bureaucracy and very little resources for the cold face. And that's a problem. And we need to fix that. Now, if you go into a national health system, you'll use all that is available. So all these private hospitals that seem to be better equipped, have better human resource plans, can then be accessed by all citizens. And the central fund will pay them on behalf of all citizens. You then give the public hospitals an opportunity to meet the standard. Remember, if you have a public hospital that, for example, has 400 beds and it's supposed to have 1,000 nurses and it only has 200, how do you expect it to give quality services? If you have a hospital that has floor beds, you expect it to give hospitals. I have a niece that just got married in Rahima Musa Hospital. You have women in labor, in the corridor, in chairs. You have labor wards that are empty in the private institutions that are driven by an act of parliament. They are not driven by people's own money. They are not like private schools or private security. They are driven and supported by an apartheid of legislation called the Medical Schemes Act. And you come and sit here and pretend like we care. No, we don't. We just to be privileged. Everybody will tell you, hey, I have a medical aid. Leave it alone. You try and speak to parliamentarians about them being MPs for all citizens. They say, hey, once you try fixing healthcare, leave my power med alone. So people are hiding behind apartheid legislation that gives them privileged care, is disabling us from building a healthcare system that will be a healthcare system for all, as the president alludes. As long as we have the two tiers, as long as we have public for the poor, private for the basic act of, we are going nowhere quickly.
Doc, our connection is not solid, but maybe just a last question, if we could manage to get this through. If you speak to financiers or insurance companies, they'll tell you the first thing that people shave off in tough times is actually medical insurance. And so it is in our best interest that we get everything to work in this country, right? And so what is it then that you and I can do? What is it that the lay person can do, if not anything but to apply pressure so that it works for the benefit of all?
What we all have to drive for, if we are the caring society that we claim to be or that we want to be, is that health should largely be funded through taxes. So there's nothing like during bad times you don't pay tax. It's taken off tax, so it's funded. So it's not left to the individuals to find their own healthcare. We've given lip service about primary healthcare. We've got to make it work. We've got to provide health information to people, but it is our responsibility to be as healthy as we could be, to reduce the burden on the healthcare system. We need to be able to take health services to the people. That's why primary healthcare is important, inside their homes, inside their communities. We move from our hospital-centric system. So tax-funded healthcare system that is the same for all of us, with common entry points for everyone. So instead of me having my specialist, I should be talking about my family doctor, my GP. And the GP should have a healthcare team that helps him or her take care of the members of the community that they are responsible for. And we should be promoting well-being at that level. And primary healthcare, early detection of disease so that you can treat it when it is easier. If you look at cancers, for example, because of our health system that doesn't work well, cancers are caught late, at great cost to the healthcare system, and people's lives are at risk. If you have a system where we can have early detection, you'll be able to provide cures at a much cheaper cost of providing healthcare services. So it's about a publicly funded system based on taxes, a system that's common for all of us. None of this private discrimination, hiding behind private and saying it's my money. It's not your money. It's statutory money in medical aids, which means there's a statute of apartheid that separates South Africans between rich and poor.
Dr. Kgosi Letlape.
Cross-fertilization, and we should take care of each other.
Unfortunately, that's all the time we can afford this afternoon, but thank you very much for your contribution.